Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today, we'll be discussing hernia prevention and treatment. What is a hernia? What causes them? Who's most at risk? And what can we do about it? Our discussion today will hopefully address these and other questions and help us separate fact from fiction regarding what is a very prevalent medical condition. My guest is my colleague, Dr. Guy Sugiyama. Dr. Sugiyama is System Chief of General Surgery for Northwell Health and a Professor of Surgery at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Guy, welcome to Well Said.
Thank you very much, Ira. Happy to be here.
So first, you've been a surgeon and a medical educator for a long time, but the last couple of years have been unlike any other couple of years. So I just want to start by asking you how you've been managing during this extraordinary pandemic.
It's been difficult. We've had things that we never expected, like, performing a medical educational sessions through a new platform like Zoom and Microsoft Teams. I've never thought that we'd be having lectures to a internet platform, but it seems like we've been able to adapt to utilizing various technological advancements. And, I think we've got some positives out of it. We have also seen difficulties with patients who've delayed their care, and I'm actually starting to see more of that over the last 6 months with people who haven't had their care coming out of the house, trying to get their hernia addressed that's been there for 2 years or 3 years.
Yeah, we actually did a show about a year ago about people delaying care. And I guess we'll get into that a little bit with specific regard to hernia care a little later in our conversation. But to start, maybe I can ask you to just define what a hernia is and whether there are different types of hernias.
General hernia is like a weakness or a soft spot in your muscle or tissue where organ or, any of the stuff that's inside your abdominal cavity could protrude out. So hernias could be in the groin. That's probably the most common things we see. Hernia could be present at the belly button or above or below the belly button. And, there are instances where you see hole within your abdominal cavity where you have a hernia between where the stomach connects with the esophagus, like a hiatal hernia. So there are various hernias that are present within our body.
So basically, it's a weakness or a hole that allows something to go where it shouldn't ordinarily be.
Yes, that's pretty much the general definition. So the most common symptoms that I've heard from patients over the years is I have a bulge in my groin, I have a bulge in my abdomen, or I have a protrusion in my groin or my belly, and it's oftentimes not symptomatic or have pain or other discomfort associated with it. They just notice that there's a lump there, and then they notice that it's starting to get bigger. That's the most common things I've seen people present to the office with. A lot of times they have no pain, and other times they have pain. So we typically divide the hernias into people who have pain or symptoms and people who have no symptoms. So oftentimes people could with no symptoms, and the only thing they notice is the lump.
What causes these to develop?
Depends on where the hernias are located. Most common ones, again, is groin. It could be congenital or, again, weaknesses in the muscle over the years. Belly button, again, they've had umbilical hernia since they were born, or belly button hernia, and they haven't noticed it. As they start to gain weight, it starts to get noticeable, and they notice that, they have their belly button out. And the other people would say, I've always had outies, and I never thought that this was problem until someone said, "Oh, that has gotten bigger over the last few years," and they get their families or friends say, "You better go get that checked out," and they come and they say, "I knew that this was a hernia." It's actually quite common for someone to come in and say, "Oh, I didn't know this was a hernia. I've known this for since I was a baby."
Now, you mentioned that some people have this because of a weakness in the muscle. Is that something they're born with or something that develops over time?
So again, the muscle weakness is something that you develop over time. It's just kind of wear and tear, I believe. That's the reason why they're starting to get, and then, with repeated motion, they can start to cause more atrophy of muscle and so forth. So again, you see it more often in the older population, but you can see hernias from newborn, all the way to people who are in the 80s and 90s.
People sometimes develop muscle weakness as a cause of a hernia in the abdominal wall or in the groin. The common belief is that if you lift something too heavy, you can get a hernia. Is that a real thing?
Part of it is that it's kind of what prompted them to remember it because they exerted themselves. It's not always, the one cause why they get the hernia, but oftentimes it's that inciting incident where they were doing a heavy lifting and then, they felt that, a lift, and then they feel like that was the reason why they caused it, but probably the weakness was there before that incident, and it's just that because that sudden move, they felt like that's where that cause of the hernia came from. But I often get patients, come into the office, say, I was lifting this heavy box, and then I felt this sharp pain, and then I noticed that there was a lump there. So, I mean, it's probably, coincidental, but, it is a common statement I get from the patient when I say, "What brings you here?" And they say, "I was lifting this heavy box, and then I felt this strain in my groin." Obesity is definitely a risk factor for developing hernia. People who've had previous surgical procedures, so any incision you've had is a risk for hernia. People with the collagen disorders or people who have connective tissue disorders are at risk of hernias.
Are hernias dangerous?
It can get dangerous. If you're looking at it from people who come to the emergency room, oftentimes they have pain, and sometimes it could just be a piece of fat that we have inside our abdomen that's stuck, but sometimes we can get our intestines get stuck in there. When that happens, there is a possibility of your intestines getting in danger of dying in that hernia sac. So it is something that can get dangerous. So when it does get symptomatic, it's usually recommended that we definitely fix these hernias. Majority of the time, you can actually tell whether this patient has a hernia or not. So it just kind of may help to divide up the abdominal wall and the groin separately. For the abdominal wall hernias, if there is a lump palpable, 9 out of 10 times you can tell that it's a hernia, but other times you may be unsure whether you're dealing with a little piece of fat like a lipoma or a fatty tumor that's stuck in your abdominal wall. In those instances, we may start with an ultrasound or follow with a CAT scan to confirm your diagnosis. With the groin hernias, again, if there is a lump, it's easy to diagnose, but for whatever reason, we can't have a good visualization whether they have a hernia or not. Then next step is usually an ultrasound, as this is non-invasive. There's no radiation risk, and if they're still inconclusive and patient still complains of a symptoms in the groin, then we'll proceed with CT scan or MRI.
Do you generally recommend that patients have these fixed?
So any patient who has symptoms, I always bring up the option of repairing the hernia as it's starting to become symptomatic. It's probably time that the body's telling you something's not right. So I usually go over the option of fixing it. Some people are so hesitant to not have any surgical procedures done. In those instances, I advise them that if they, have symptoms such as nausea, vomiting, a lump that cannot be pushed back in, then they have to go to the emergency room. But in general, if they have symptoms, I actually do recommend fixing it.
And when you say fixing it, you're talking about an operation, right? There's no medicine or other treatment for this.
This usually again, this is a kind of a man-made, not man-made, but a hole or a defect where intestines and abdominal content is protruding through. So the only really way to address it is with surgery.
Can you describe, again, maybe separating the abdominal wall hernia from the groin hernia? What does that repair actually involve from the patient's perspective?
So let's just start again with abdominal wall. You can have, again, various type of hernias. So with abdominal wall, we can have what's called umbilical hernia or a hernia that's above the belly button. Umbilical hernia, which means a belly button hernia. You can also lump together a hernia anywhere along the abdominal wall as a ventral hernia. And then anytime they have a previous incision, whether they had surgery with the camera, a laparoscopy or open, that becomes an incisional hernia. So that also, again, is along the abdominal wall. Based on, surgeon preference as well as patient preference and, the expertise of the surgeon, nowadays they're fixed either with open approach, that means they're getting an incision, larger incision than what you have gotten, or we have options of performing minimally invasive hernia repair. Laparoscopy instruments are utilized to perform these repairs.
Does the repair pretty much just involve sewing up the hole, or is there kind of more to it than that?
So again, we kind of look at the overall, is it an umbilical or, other larger incisional? Most of the time, the umbilical hernias are repaired either with just sewing up with sutures or utilize a patch. So some of the numbers that we look at is how big the defect is. If you look at any of the literature, anything more than 2 centimeters is an option to use a patch to fix it. Anything between 1 to 2 centimeters is depend on, at the time what the surgeon decides. Anything less than 1 centimeters, we can actually go ahead and perform a suture repair or just use sewing up the hole. But other, larger incisions would definitely involve both combination of sutures as well as some kind of mesh materials.
Yeah, so you're using patch and mesh synonymously? Are those the same thing?
Yeah, mesh, patch, they're the same thing, yeah.
And what is that actually made out of?
There are 2 kind of major types that are utilized in U.S. Today. One is made out of polyester. The other is polypropylene, so basically a plastic material. The companies have meshes that come preformed with certain sizes. So, we have patch that are as small as 4 centimeters or like a 1.5 inch patch to something that's as large as 12 by 16 inches or, a large size mesh. Yeah. All depends on how big the defect is.
I suspect that some of our listeners have heard bad things about mesh. I don't know, that it gets infected or that it can cause other problems.
Yeah, so this is actually a very, very common topic that gets brought up by the patient to the point I had to actually ask a company to, give me expired mesh so I can at least show the mesh to patients because they're very concerned. And some of the badness that they've heard, it does occur on an occasion, mesh infection where they have chronic drainage with pus coming from the wound, from, intestine eroding to the mesh, causing, intestinal contents to be exposed. There are, horrific, complication that's been described, but, that doesn't happen all the time. And again, a lot of times it's multifactorial why they get these complications from, mesh repairs, but that is something that I actually will go over when I go over the mesh repair with patient about that it's a permanent material that will stay in their body, that there's always a small risk of mesh getting infected. But yes, the worst complication is really when the mesh has erosion of the small intestine, the large intestine, and they have to undergo revisional operations. It's not very common. I specialize in taking out infected mesh and complications related to mesh, so I see a lot more of those than other people. But, normal, practicing general surgeons out there are not going to, encounter it on a frequent basis like I do. Groin hernias has undergone quite a evolution over the last 30, 40 years. Prior to the uses of mesh, they used to just basically rearrange tissues and have fairly successful outcome, but there were still patients that were undergoing, repair for recurrences. There's a clinic out in Canada that kind of popularized their technique called the Shoedice technique, where they basically sewed together the layers of the tissues in the groin. But outside of that clinic, they've never been able to reproduce the success that they've had at the clinic. So most of the hernias now, about since the mid-1980s, the groin hernias are primarily fixed with some type of mesh material. If you look at, let's say, room full of men, 1 in 5 eventually develop inguinal hernia and will get their hernia fixed. So it's a fairly common procedure that's been done. If you look at the general surgeon's practice, that's probably one of the most common procedures that they perform. Women are 10 times less likely to get hernias. With the women, they have a higher risk of incarceration, strangulation. So, we typically like to recommend fixing it for the females.
Why are men at such higher risk compared to women for these things?
Again, with the way one of the things that we talked about was the hernias and the groin was it could be congenital. They have a congenital defect that allow the weakness to be present already when they were born. It might not have been present at the time they were born, but as they get older, it comes together. It comes to fruition, and they have to be have their hernia addressed. So this is more of a congenital form that the men get simply because of the way our reproductive organs are developed.
Okay. So are there new techniques on the horizon that are likely to change the way you and other surgeons approach this, I guess, fairly common surgical problem?
So again, let's just kind of go to separate out the abdominal wall and the groin. The open surgery is still prevalent, and there's still people that are still, need open surgeries. A new thing that's picked up over the last 5 years in the field of general surgery related to hernia is utilizing robotic platform, or maybe people have heard the robot called the Da Vinci robot to fix the hernia. It's been picked up by surgeons across the United States, where I think most people who do this will agree that this is the way in which, abdominal wall ventral hernias are getting fixed compared to the older ways in which we used to use a laparoscopic approach. Again, they are kind of similar. It involves camera, it involves instruments. The only difference between a laparoscopic and robotic platform is the robotic platform. The surgeons control the instruments, but the surgeons are actually sitting on the console away from the patient's bed and allowing the instruments to perform the surgery. And that seems to be where the hernia repairs are going in 2022.
And is there any demonstrated benefit from doing this robotically as opposed to directly with the surgeon's hands on the instruments?
So one of the main difference between a laparoscopic robotic approach is that in most hands, again, there are surgeons out there that are capable of doing it, and the laparoscopic instruments are a straight stick, so it's like a stick surgery, or sometimes I describe it as a chopstick surgery. You have two sticks that's in your abdomen, trying to address a hole. So very, very skillful surgeon might be able to close the hole up and then utilize that plastic material, the mesh, to reinforce it and provide a good care. But if you look at the average surgeon out there, it's a skill set that's very, very difficult to teach. As can you imagine a hole in the roof and you're trying to get there with a straight stick versus an instrument that actually has a wristed movement like a robotic approach, and it just makes the surgical repair easier to address that hole. So in the olden days, if you didn't close the hole, you just basically patch that hole up with the mesh very large. So if people who have had laparoscopic hernia surgery done in the 20 years ago, most likely there was a hole, large mesh got placed, and mesh was basically secured the abdominal wall. So the hole never got addressed. It was just patched inside. But with the robotic repair, the hole is actually first closed, then the mesh is reinforced against the abdominal wall. So even though it's very similar, there is a little nuances in the way the hernia is fixed using a robot versus the laparoscopic repair.
And from the patient's perspective, that's likely to lead to what? Faster recovery or a more durable repair, both?
More durable repair. Some say less pain postoperatively. But, I think it's only been out for 5 years. As we know in medicine, sometimes things don't come out into 5 to 10 years after. So next 5 to 10 years is when we're really going to see whether this is a, more durable, better repair. I only do hernias using a robot versus laparoscopy unless I don't have the robot available, just because I feel like it's a better repair. But, only time could tell whether this is the better, durable compared to other modalities. But this is really something that's being adapted across the world in terms of choice of modality for fixing ventral hernias.
Well, that's very interesting. I mean, I wonder, are patients starting to ask for that specifically? I mean, is this kind of a marketing thing, or I'm just curious where we are right now. I mean, if somebody walked into your office and you thought they needed a surgical repair of a abdominal wall hernia, are you generally recommending that they have it done robotically?
So again, we look at patient as a whole. So I kind of have a little bit of a holistic approach to, is the patient candidate to have surgery with little tiny incisions? Are they somebody that can tolerate having their abdomen inflated to fix? But if the answer is all yes, and they are a candidate, I do. And if I think that is technically feasible, I do recommend it. But going back to your statement about, is it a fad or is this something that patients are asking for, there's been a shift in patients' request probably over the last 3 years. 5 years ago, most people weren't even aware. But the adaptation of robotic surgery has been enormous in the field of urology, where over 90% of the prostatectomies are done using a robotic platform, and a lot of the gynecologists are now performing their surgery with a robot. So I think the word robot is not foreign to patients anymore. They're actually hearing about it from their friends or their family members, and I guess they've had their share of good experience with it. So, a lot more times I've been asked to do it, or I've had patients who had robotic surgery and now they have their own incision or hernias from that procedure, and they're asking whether that hernia from the various procedures that were done robotically could be done again, using a robot. So, yes, it seems to be gaining more traction.
That's very interesting. If folks are interested in learning more about some of the topics that we've discussed today, where would you suggest that they get some more information?
National Institute of Diabetes and Digestive Kidney Disease. I'm actually pulling it up right now, and they have a fairly good topic and pictures about hernias in general. So, anything I think maintained by an academic medical center or a governmental side, I think is a good place to start.
I want to thank you so much for joining me today.
Thank you for having me.
For more information about this program and to find past episodes, please visit sites.hofstra.edu/wellsaid. You can also subscribe to our free podcast available on Apple Podcasts, Stitcher, or wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.